Assalamualaikum warahmatullahi wabarakatuh. And very good evening to everybody. I know this is going to be the last topic for today. All of you are excited to go home since this already 2 days here. By the way, my topic going to be slight interesting here. Acute pulmonary embolism. Many of us saw or encounter cases with acute pulmonary embolism. Sometimes we might miss this diagnosis. Okay, so it's going to be very important topic because some of these patients may be underdiagnosed. Okay, it's okay to overdiagnose rather than underdiagnose acute pulmonary embolism. So my outline of presentation, we talking about this overview, clinical presentation, evaluation, diagnosis, and also a bit on the treatment. The most important thing of this acute pulmonary embolism is going to be the diagnosis of acute pulmonary embolism, because sometimes it can be challenging, sometimes it can be to other diseases. So therefore, I will spend a bit more time on the diagnosis of acute pulmonary embolism. Very long guidelines by EAC guidelines on acute pulmonary embolism 2013. Recently, there's not much of updates on acute pulmonary embolism, but suffice to say that we kind of comfortable with the diagnosis. The guidelines from EAC. So some of the management have been taking from these EAC guidelines. Quite straightforward. You can refer to in the internet. So basically, acute pulmonary embolism, anything that obstruct the pulmonary artery or any of its branches by any materials. It could be thrombus, it could be tumor, it could be air or fat. Okay, that originated elsewhere in the body. So for the sake of this talk, I'll be talking on this thrombus rather than tumor, air or fat. Okay, because the management can be slightly different. So we talk about thrombus, they need to anticoagulate, so that there's a difference. Some of us might encounter acute pulmonary embolism in emergency department, or have seen cases. Some of these doctors use acute, subacute, or chronic. Some doctors use hemodynamically stable or hemodynamically unstable, or is it massive or submassive? No? Or sometimes the radiology say based on anatomical conditions such as saddle pulmonary embolism, or is it submental pulmonary embolism. So these all nomenclature. So nomenclature to denotes what is acute pulmonary embolism, whether this patient has massive or submassive. But for the sake of clinical scenario that we are dealing with, it's better to use hemodynamically stable or unstable. Alright, so the temporal pattern of presentation could be acute. So mainly it will be acute. Patient with acute pulmonary embolism typically develop symptoms very sudden. Okay, immediately after obstruction of pulmonary vessels. Subacute, this patient has usually comes with symptoms preceding days to weeks and subsequently becomes acute. For chronic, those patients comes with symptoms that slowly develop over a period of time, or sometimes can be many years. So this patient we say chronic thromboembolic pulmonary hypertension, or CTEPH. But for the sake of discussion this evening, I'm not going to touch on this chronic pulmonary embolism. Talking about this presence of or absence of hemodynamic stability, like I said before, either unstable or stable PE. Sometimes people say hemodynamically stable means unstable means massive, or some clinicians might say high risk pulmonary embolism. So make sure you don't confuse with the terms. When you say stable pulmonary embolism, it could be submassive, okay, or intermediate risk pulmonary embolism, where there is associated with right ventricular strain, or sometimes can be denoted as low risk pulmonary embolism, where there's no evidence of right ventricular strain in the echo, for example, but there is thrombus in the could be distal to vessels. Now we we talk about this hemodynamically unstable pulmonary embolism, this is very, I mean, for this evening, you have to remember this. Hypotension that defines as systolic blood pressure less than 90 mmHg, or a drop of systolic blood pressure more than 40. So if the patient is known to have hypertension, blood pressure is always 150, 160, come to you with blood pressure of 100 or 110, you cannot say that this is normal. It could be relative hypertension. Okay, and the drop must be a period of more than 15 minutes of hypotension. And sometimes this patient requires vasopressors or ectopic supports. So even though you have run quick, this patient requires vasopressors. So this hemodynamically unstable and not explained by any other cause such as sepsis, arrhythmias, left ventricular dysfunction from MI, or hypovolemia because of bleeding and so on. Okay? So you have excluded any other things, and suddenly you cannot find what is the cause of hypertension. So you might think of pulmonary embolism. Okay? And usually it's caused by large thrombus, or sometimes people call massive. Okay? But some cases comes with small pulmonary embolism with underlying cardiopulmonary disease such as COPD and so on. Therefore, the term of massive pulmonary embolism does not necessarily describe the size of thrombus, but it is more of hemodynamic effects. For hemodynamically stable pulmonary, anything does not meet the definition of hemodynamically unstable PE. So if you talk about stable, means the blood pressure is okay, there's no drop in blood pressure, okay? And the spectrum of severity within this population ranging, okay, right from small, sometimes patient may be mildly symptomatic, sometimes asymptomatic, or sometimes what we call low risk pulmonary embolism. Mild or borderline hypotension can be stabilized with weight. Sometimes this patient, after you give weight, the BP pick up. Okay, and some patients may have right ventricular dysfunction, known as submassive or intermediate risk pulmonary embolism. Okay. So you can say that massive unstable hemodynamically unstable PE or high risk pulmonary embolism. So bear with this term. Yeah? And sometimes if you read the CTPA report, sometimes they don't this report as saddle pulmonary embolism. Okay, sometimes they say lobar, segmental. As it goes towards the distal of the vessel, it becomes lobar, segmental, and then subsegmental. Even though the radiologist report as saddle embolism, but only about 22% are hemodynamically unstable, and usually associated with mortality of 5%. So we talk about this pulmonary. We talk about pulmonary embolism. You have the branches of pulmonary right and left, and then right giving rise to the segmental. Lobar, okay, and then the segments of the pulmonary. So depending on how much is the thrombus that goes either to right and left, so giving rise to hemodynamically unstable, you say it's a massive. So we talk about thrombus. I'm sure you remember these triads. During the undergrads, the lecturers always ask this so-called famous question, Virchow's triad. So there will be endothelial damage, hypercoagulable states, and also stasis. So all of these factors giving rise to the formation of thrombus. Okay, as you can see here, some of the causes, right from the endothelial dysfunction by smoking, hypertension, and so on. So you see some of these can also be due to defect in the blood, due to deficiency of Pyrethrin and C and S deficiency and so on. And some are acquired due to malignancy, patients who had oral contraceptive or hormonal therapy, pregnancy, obesity, and also it because there's consumption and so on. So and also stasis because of polycythemia at the primary or secondary, or sometimes can be due to immobilization due to fracture, fall, and so on. Alright, now we go to clinical presentation, how you recognize pulmonary embolism. Sometimes this patient may come to you suddenly breathless, cannot give you history, but from the clinical examination you might find that this patient had, very tachypneic, the CO2 is low, and there will be hypoxia, the PO2 also low, the patient become very breathless. In some cases of severe or there's a pulmonary infarction, that patient can have hemoptysis. Chest pain, very throbbing chest pain, sharp, very sudden, usually in the acute pulmonary embolism, right? And the distal peripheral also become bluish because of low perfusion and so on. So remember, when you have pulmonary embolism, so think of these pictures. This patient very breathless, sinus, tachycardic, hypotension, and also hypoxia. So if you look at this presentation, most of this patient comes to you with dyspnea. Up to 73% of patient comes with dyspnea in acute pulmonary embolism, and about up to 60 to 70% comes to you with fluid chest pain. Okay, it's really atypical of MI, but sometimes when patient comes with chest pain or MI or uncertain and so on. But think of outside the box. Okay, when patient comes to you with chest pain, hypoxia, we might want to think of pulmonary embolism as well, because these two presentations very high in the list. Some patient may come to you with cough, sometimes mimics with pneumonia, and also hemoptysis. Okay, sometimes this patient, when you examine the patient, very tachypneic, there is a crepitation in the lungs, there is tachycardia up to 30%, presence of false heartbeat, and also some patient or minor patient comes to you with circulatory collapse. Means the blood pressure is low, there's low perfusion, low pulse volume, and so on. So initially, when patient comes to you, when hypotension and so on, we think of pulmonary embolism, we need to do things. We try to do and see whether this patient is polycythemic. Give you some of clues whether this patient has CKD and so on. Because if you want to proceed this patient for CKD and so on, the renal function, ABD is very important. You need to see whether this patient has hypoxia, whether there's either there's a compulsory respiratory component or not. Okay, and sometimes troponin I can be positive. Okay, troponin I also can be positive because of myocardial injury. And D-dimer is important in intermediate and low risk pulmonary embolism, but in high risk or massive pulmonary embolism, D-dimer you don't need to send. Okay, we'll see flowchart afterwards. Another thing that you need to think, if you think of pulmonary embolism, where you can't explain of any cause of hypotension, hypoxia, you might want to arrange for CPA. Sometimes if you have bedside echo in ED, where the echo machine is very nice to see the views, you can see RV dysfunction. Yeah, but sometimes this echocardiography depends on operator. Okay, and also whether this patient is stable or not. And ultrasound Doppler of lower limbs to exclude deep vein thrombosis that is lodged to pulmonary. ECG, of course, the patient comes with chest pain. You do ECG, and most common patient usually the ECG is non-specific. Most common finding, there will be a tachycardia, non-specific T segment changes, about 70% of patient. And if you have a PE changes, you might remember S1 QT3, it's suggestive but not pathognomonic. Okay, and sometimes this patient might have a right ventricular strain with new incomplete right bundle branch block, up to 10% of cases. Some patient may come to you with already very bad condition. They come with you with atrial arrhythmias with for example, atrial fibrillations, bradycardia less than 50 or tachycardia more than 100, new right bilateral block, inferior Q wave, and also anti-ST changes. So think of when you have a PE, when you don't see any of these S1, 50, doesn't mean that this patient is not having PE. So remember that. But if you see, may be suggestive, okay, but it's not confirmed. Right. So when you do a chest X-ray, sometimes you might want to see some subtle changes. The Hampton hum size, Hampton hum. Okay, you can see here. Okay, this is due to probably infarct. Yes, segmental infarction there. Okay, which correlate with the CT scan there. Okay, and sometimes this Western mark sign, okay, is due to these changes because of the thrombus, and it can be sharp signs. I'm sorry, this is not really clear. But however, just give you a clue. Okay. So the key factors of contributing to hemorrhagic collapse in acute pulmonary embolism is basically a cycle. If this patient, if you detect an early stage, you can correct. Okay. But then if the patient already comes to you very bad, systemic blood pressure low, and also reduce cardiac function, sometimes this patient will be cardiac shock and there will be high mortality. So initially this patient has, because of massive pulmonary embolism and the pulmonary artery, there will be increased RV afterload. Because already blocked there, the pressure go down, there will be RV dilatation. You can see the echo sometimes. There will be right wall tension, increased right wall RV wall tension, and there will be changes in new hormonal activation and also myocardial inflammation. So that's why troponin or CT can be elevated or CKD can be elevated. Okay, so it will be RV ischemia leading to reduced contractility, reduced output, reduced LV load, therefore reduced cardiac output, and leading to hypotension and cardiac. Subsequently, if you don't tackle early, the patient will die in front of your eyes. Alright. So these are the predisposing factors for venous thromboembolism. You can see that when you have this patient, you might want to ask your, the relative of this patient. Okay, sometimes this patient already taken it in front of your eyes, or cannot give history. You ask the family history. There is a history of recent fracture, for example. This patient is not mobilized. This patient has hospitalized for heart failure, not mobilizing for the last 3 months. Okay. This is surgery for the lower limbs, hip and knee, major trauma, okay, MI because of co-embolization, for example, history of previous venous thromboembolism in the case of either acquired or okay. So let's go towards this. You can split this all these factors. And these are other risk factors. You can see your risk factors: bed rest more than 3 days. Sometimes if you on leave, bed rest, poor embolization, but this is risk factor. Okay. So when talk about this pulmonary embolism, okay, hemolytically unstable patient, the mortality is high as more than 50%. Okay. But the prevalence is quite low, less than 50%. Okay. So just to show you the hemolytically unstable is more than. Okay, time's up. Thank you. Okay, because I'm last speaker, I've got the privilege to give. Okay, thank you. Alright, so let's go to the diagnosis. It is very important for you to know that this original version and also simplified version of the pre-test probability. You can see this in ESC guidelines, where you can score the patient within the Wells rule. Okay, and also you can use device score. Okay, then you can see whether the patient is having high clinical probability or not. Okay, when you have high risk pulmonary embolism, you see if you suspect this patient is pulmonary embolism with shock and hypotension, do a CTPA first. Okay, because in our hospital is widely available, you do a CTPA. not, if you have echocardiography, you see the RV strain dysfunction or RV strain pattern or RV dysfunction. Okay, but still, echocardiogram you still need to do CT angiography. So basically, you need to do CT angiography. Yeah. So CT angiography positive, confirm PE lah, embolism, and then you initiate primary intubation therapy. If it's not high risk, intermediate risk or low risk, so you need to see the D-dimer. If the D-dimer positive, proceed with CTBA. If high clinical probability of primary embolism likely, do CTBA. It's still safe. Now I'll go very fast. The diagnosis of primary embolism, as we mentioned, CTPA is very important, or bedside transient echo, but I said there's a limitation. So always go for emergency CT angiography. Without shock, always go for validated criteria. You see the D-dimer. The D-dimer positive, you might want to proceed with CT angiography. Okay. Alright, so I go very fast. And then you might want to consider lowering ultrasound if there is evidence of to look for DVT and so on. Yeah, that to be recommendation. So I skip prognosis. Prognosis, just remember you have this PESI and also SPESI. Okay, you prognosticate this patient, the scores after the patient discharge and so on. You have your point, how many risk of mortality and so on. So you can go back and check what is PSI. Okay, so this is another important slide. When you have a clinical PE, either shock. If shock, confirm the diagnosis by CT angiography, then you need to initiate primary reconfiguration therapy. Okay, if there is no hypotension, then you need to confirm the PE first by doing D-dimer as we discussed, and then you need to prognosticate the patient and see whether this patient is intermediate or low risk. Low risk, you can consider early discharge, okay, and home therapy. If it's intermediate, you need to see other modalities, either echo or CT angiography. Consider rescue proportion if anticoagulation fail. But intermediate low risk, you also need to anticoagulate the patient. So basically, high risk primary reperfusion, intermediate risk anticoagulation, low risk you can discharge the patient with home treatment. I'll just go very quickly on the initial treatment. You see respiratory support, you need to assess whether this patient needs to be ventilated or not. But you need to target the oxygen more than 90%. Respiratory support, you can use intravenous fluid, usually about 1 to 2 pints of fluids. If it's not responding, you need to start with vasopressor therapy. And also you need to empirically treat. Okay, you need empirically initiate anticoagulation if you suspect high probability of pulmonary embolism. So how to give? In our hospital we have this central kinase. We give 250,000 units, loading dose over 30 minutes, followed by 100,000 units per hour, over 12 to 24 hours. Okay. But if you assess the patient does not have any risk bleeding, okay, almost finishing. You can give a certain regime 1.5 million unit over 2 hours. Okay, it's slightly lower dose or slower dose in acute myocardial infarction, so slightly slow. Okay, if you have active place, then give 100 mg over 100 mg per over 2 hours. Okay, so I highlight central kinase there. So bear in mind the contraindication for thrombolysis, you can go back and check. And this another thing that parenteral anticoagulation for intermediate risk patients, you might want to consider enoxaparin. Okay, that you have for fondaparinux. The fondaparinux is not 2.5 mg as in case of acute coronary syndrome. Bear in mind it's according to body weight. Okay, less than 50, 5 mg. 50 to 100, 7.5. Remember that. Okay. Alright, so I think I concluded this all the recommendation by ESC guidelines. You can go back and check. Some of these already mentioned in the previous slides. Alright. Thank you very much.
Thank you, Dr. Muhammad.